Second, it echoes. So we should keep quiet until I literally silence it.
Sure.
This meeting got it. Okay. Oh, it is already silenced. Okay. Now, you told me you sent me a link to that patient, correct?
Yeah,
Testimonial?
it should just be in one of your top emails.
Yeah. Now, Amanda, do you want to start?
Ready? Yep. Hi, guys. Thanks for joining. This is Essence of Medicine. Today, we're going to be talking about the miracle joint. My name is Amanda Armagast.
My name is Alyssa Haber.
My name is Mike Yeager.
And I'm Dr. Abbasi for Essence Podcast, Essence of Medicine. And we are going to talk about the miracle joint. That's a catchy name, Alyssa, isn't it? Miracle joint.
It sounds marvelous to me.
Yes, like Captain Marvel or Captain America.
Exactly. Something you can't live without, right?
Yeah.
Especially because it's really not a joint, right?
Oh, good one. Good one. Mike, there is another name that we specialists, we call this joint. One is the miracle joint, and we come back to that, why it's called miracle joint. The other one is called
Chameleon joint.
Chameleon joint, exactly. So, and we are going to talk about both of it. Why is it called chameleon joint? Okay. So, I like to start this with the patient testimonial, and obviously we put this patient testimonial online, and everybody can go and look them up and find out about them. But this is a patient testimonial I like to share with you. Are you guys able to see that?
Yep.
Yeah. And just a little bit of a trigger warning for people. This is a little bit of an emotional testimonial with talks of suicide.
Okay. So, well, first start a young man who has the family and is in work. And this is a 6-minute conversation. I'm just not going to probably show all of it.
Miserable.
That made me really sad. He said you were
That I was ready to end it. I was like, I can't continue like this. I couldn't sleep at all. I was miserable. My family was miserable.
That made me really sad. Now, I want to just stop here. This is available online, right?
Yes, it is.
Everybody should actually go listen to this, because this is a reasonable person who has been going from place to place, from spine surgeon to spine surgeon, and they all look at his spine and they said, there's nothing wrong with you. He has been directly told it's all in your head. He believed it's all in his head himself. He said, I wasn't useful to me and myself, to my family. I was ready to end it all. Now, the good news, he didn't end it all. We did a 20-minute procedure. He's off narcotic. He's back to work. After 20 procedure, that was 20 minutes. Hence,
Wow.
Miracle joint. A joint that when you have been told for years, nothing can be done, is nothing wrong with you, all of a sudden you do a 20-minute procedure and he regains his life back. Now I want to come back to that chameleon joint, Mike. Now, do you have any idea? And this is not a quiz. You don't get graded for that. But do you have any idea of why we call it a chameleon joint? It is related. Miracle joint and chameleon joint are related.
Does it have something to do with maybe disguising itself as something else?
Yeah.
From what I know,
what this chameleon does.
Chameleons change their color based on their environment or their surroundings. So to me, I would.
They are a leaf. They appear. They are a branch of a tree. They appear. They are a piece of stone on the ground.
Correct.
They can appear as anything but a chameleon. That is what this joint does. It can appear it's a pelvic floor problem. It can appear cause symptoms that is comparable with lower lumbar spine problem. It can appear it is almost anything in that area. Hip problem, it can cause symptoms of a hip problem. It can give you radiculopathy. It can give you symptoms of a neuropathy. So, and that is where these two terms come, the chameleon joint, because it can appear as something else. And people like, you bring me your heart problem all day long, and I'm going to look at your spine and tell you there's nothing wrong with your spine, because I'm not a heart specialist. And what percentage of the spine surgeon do you guys, Amanda, do you believe are trained to treat sacroiliac joint?
I would say like 15%.
Yeah, very good. You have been too long with me. Less than 20% of the spine surgeon are trained to deal with the sacroiliac joint problem. Now, let me share a few slides here, but Mike, I'm going to come back to you. What is sacroiliac joint? What is it?
So as the name implies, it's where your sacrum meets your ilium, or the pelvic bone.
Mm-hmm.
And so it's super important because those are the just two massive areas of support in your body. And since we're, bipedal organisms, we walk upright. We carry a lot of axial weight. So that joint carries a lot of weight.
I like what you said, we are bipedal. Amanda, is that the term you're familiar with, bipedal?
Well, I can put two and two together. Bi, two, ped, feet.
Yeah, it has nothing to do with sexual orientation. Bipedal.
Don't worry, I don't think anyone.
Now, why is it important though? Because in a just the orientation of that, like when we dissect our pigs, first of all, the orientation of the sacroiliac joint is very different with them, but as well, not their entire weight is hanging on the sacroiliac joint, whereas about 3/5 to 4/5 of our weight is hanging on the sacroiliac joint.
When I was learning about rock climbing, I actually learned that women have their center of gravity in their pelvis and men have their center of gravity in their chest. Does that have anything to do with that?
Well, it has something to do with how much of your weight you're putting on the sacroiliac joint. It practically you're suspending your entire torso on your pelvis. That is where sacroiliac joint come to function. It's holding you up, and if you're doing it like contrary to a pig or a cheetah or a lion, where maybe just less than 1/5 of their weight is on the sacroiliac joint, with human, the vast majority of your weight is suspended on your sacroiliac joint. But what is a joint? Alyssa, what is a joint?
To me, a joint is when two objects come together to create, basically, I guess in this case, it's a synovial joint, so there isn't a bend, but it's where they come together and we call it a joint, pretty much.
Well, a joint is when two bones are articulated against each other, and the surface of the articulation is usually a cartilage.
Yeah,
right?
correct.
Now, and that motion is allowed in that joint, meaning that there are actively muscles that work on one side and another. They attach to both sides of that joint and enable you to move that joint.
But the SI joint doesn't move.
It shouldn't.
Well, let's start with anatomical thing. Who want to earn crisp $100 bill? If you name a single muscle that works attached to both sides of the sacroiliac joint, you get a crisp $100 bill.
The piriformis.
That's exactly my first guess.
Nope.
Aren't they ligaments only that connect them?
There are muscles that they traverse the sacroiliac joint and they go and act on other joints.
Is this
A
psoas?
muscle that is
Psoas is a
only goes from sacrum to iliac crest, only from sacrum to iliac crest.
Is the psoas the thing, the muscle?
Psoas goes from L1, 2, 3 goes in the front, bypasses actually pelvis completely attached to your femur.
It's all right. That's a good guess.
Thank you.
Good
like
guess
going-
though. Wow. Wow.
William
Now,
Smith is-
well,
I've-
I am safe because people have done those anatomical studies.
is it
That is
there-
a trick question. I'm not in the.
There
I'm
is-
not just being so
there's a
generous.
study.
today.
Is that what it is?
Huh? There is not a single muscle that act on the sacroiliac joint, not a single one. And if you want to go and come back with a proof of that, that crisp $100 bill is still there for you.
So it was a trick question.
It was a trick question. Yes, there's not a single muscle that act on the sacroiliac joint per se. There are muscle that traverse it, and they act on they go from spine to femur. They go from the sacrum to pelvic floor. They go from the hip and so on and so forth, but not a single one. And have you guys ever seen actually a femur head, the head of a femur?
Yep.
I had one in my hand. I took a picture of it. It is the smoothest thing you can imagine in your life. I have not seen anything as smooth, and that was in a 70-year-old person. I had a broken femur. I scrubbed him in Crookston with Dr. Fennell. He cut it out and gave it in my hand. That the articulating surface on an arthrotic on a 70-year-old person was the smoothest thing I have seen in my life.
I was about to say that. I said it's smooth because there's probably very minimal cartilage as you get older too.
Well, no, actually the cartilage is what makes it smooth.
Makes it smooth. Yeah.
The cartilage is smooth.
Say when I did a lot of hip replacements, that cartilage or that femur head was not smooth.
Yeah, well, in this case, it was a fracture. So patient fell and broke the femur neck. And that is why it wasn't that arthrotic that we did the surgery, because it was a fracture. But it was the smoothest thing on a 70-year-old person that I've ever seen. Now, comparison, this is the sacroiliac joint. There's nothing smooth about it. And this is a young sacroiliac joint. This is not an old arthrotic. So this is a normal sacroiliac joint. Do you see any smooth surface here? No.
Not as smooth as we would like.
No, well, it doesn't, doesn't really matter what we like. It is the nature. This is the nature of the sacroiliac joint. And that is a proof that it's not really made to move. Now, when is the normal time for the sacroiliac joint to move? By the way, let's need to know that we are talking about the anatomy of the sacroiliac joint. It has two parts. We call this the boomerang, or the cartilaginous or articular part of the joint. And then you have here this ligaments. We call that the ligamental part of the joint. Another view of that is here. You see the articular and ligamental part of the joint. We will come back to that, what that meaning to that is and why is it important. But Amanda, when do you think sacroiliac joint does move?
Oh, I know this one actually.
Okay, then let Mike tell us. When is a sacroiliac joint moved?
Mike knows too.
Pregnancy,
Well, not pregnancy, but delivery.
delivery.
Yeah, that is the only time sacroiliac joint actually has a physiologic option or function. But that process is actually an amazing process. Around the third trimester, some enzymes, they loosen our ligaments in pubis symphysis in the front and the sacroiliac joint to allow this joint to move. And the amount of it opens is usually, how many degrees does it open? Like an open book. Have you heard about the open book thing? The pelvis, there's an open book fracture of the pelvis when symphysis is separated, but the motion of the pelvis is like an open book. This is the pelvis, and it opens up like a book. To open up the aperture, we call inlet, or the aperture of the pelvis for the baby have more space to pass through. How many degrees does the pelvis open to allow for the baby to have more space to pass through?
30.
Wow, that would be massive.
That would be massive.
Yeah, almost 1/10 of it, about 4 to 6 degrees. That is all what it moves.
4 to 6. Yeah.
Yeah, anything beyond that is actually it would be very unphysiologic. But even then, that is the reason around the time of the pregnancy and delivery, up to 2 years after, women have 7 times higher problem with the sacroiliac joint. Even that is too much. Imagine your whole weight is, your whole body almost is hanging on that, on these ligaments. And because the baby has to pass through, your body comes and loosens those ligaments. And something you need to know about the nature of pain, we talked about that. The bone themselves are not very, they don't have pain receptors, but the skin membrane around the bone, which is called periosteum, and the ligament are very pain sensitive. And that makes sense, you know. You don't ever want to contract your arm until your ligaments, break or bone breaks. For that reason, when there's this pressure sensor there, when there's too much pressure, the pain makes you stop. Okay, so we call it a joint, is not a joint. It doesn't have really a physiologic motion. As a matter of fact, around the time of the pregnancy, where this marvelous mechanism loosen up those ligaments for that to does give you some motion, it actually causes lots of problem afterward. So who's planning to have children now? Not me. Okay, good for you.
Still only
Yeah,
me.
she's still interested.
Humanity is in debt to you. So
Hey, women are miracles. So
Yeah,
if they
that's
can do it,
actually
I
true.
can do it too.
Yeah,
yes,
thank
yes.
God for
Well,
women.
Someday.
Yeah, but does that this anatomy make sense to you, that this is just a remnant of a joint to hang our body torso from our pelvis, and is extremely ligamentally supported? I mean, we have the strongest ligaments in this area. Why is it important what I just told you, that has strongest ligament to suspend it in the front and back? Why is it important?
Because we're going to probably talk about the easiest way to access
Very
the
good.
sacro
Very
iliac
good.
joint.
So when you want to access that joint, traditionally, what did we used to do?
Did you go through the front?
No, we went front. No, this is the front. Let me show it the front of it, and then tell me again. if
Are we
you
talking
didn't-
now or in the past? Yeah, we're
Well-
not going through the
Well,
front.
in the past, we knew the anatomy in the past as well. And I'm
Right.
showing it to you for a reason. Look at this, all the nerves there, and these are the vessels. How do you feel about going from the front?
Very bad idea.
Bad idea. Yes, yes. Okay. Now, look at the back of it now. Less
Mhm.
vessels, correct? And less, so at least it didn't sound like a bad idea, go from the back. So for a long time, that's what it did. We went from the back and opened up that space. And you remember those ligaments we talked about?
Mhm.
You have to pass through all those ligaments to get there. Now, this is the truth. I did few of those open posteriorly with my attendings, and you do it only for trauma, because beside that, it is way too bloody. You can lose easily a gallon of blood there. And you have to bypass all those strong ligaments to get to the joint.
So what kind of trauma would happen that would cause you to need that done?
Mostly motor vehicle accident,
Mm.
high impact trauma. And these are really the high energy trauma that they destroy your sacrum, sacroiliac joint, and so on. And then you have to establish stability in the pelvis again.
Okay.
Now that we understand the joint, the anatomy, and location, location, location. This is even more than when you buy a house. It's about location, location, location. If you want to go from going from the front, you have to deal with major vessels and thing. Going from the back, less, but still you have to destroy all this ligament. And if you destroy them, you get into the spongiosa, it's going to bleed and so on. Now, let's go a little back in time. Already about 100 years ago, we knew that the sacroiliac joint can be source of pain. And we started doing those surgery for many reasons, but practically in 1950s, we stopped doing surgery for sacroiliac joint because literally this was one of those things like an old son, doctor, your cure is worse than my disease. It coincided that we start doing lumbar fusion, PLIF. And then for almost 50 years, it was nothing. We neglected that. We only did it for trauma because what I just described to you. Your cure is worse than my disease. 7-hour surgery, a gallon of blood loss, 3 months hospitalization, and so on and so forth. People cannot walk. They cannot turn from side to side because you're devastating their pelvis. And now fast forward in about 2000, that somebody thought, wow, there is a different way of getting to the joint. Let's bypass both front and back. Let's go through the iliac crest to get to the bone, to that joint. Like here, instead of going from the front or back, let's just go through the bone. Now, why nobody came with that idea for this long? What do you think? Mike, why did it take us so long to come back with this idea?
Was it too hard to make it through the bone in a surgery?
Instrumentation is part of it. Instrumentation is part of it, that we didn't have refined instrumentation and production of machines to enable us that. But it goes back as well to a human fallacy.
I have an idea, but I think
Go ahead. You go ahead. I want to hear that.
I guess my idea was kind of maybe lack of research. You kind of said that it was the chameleon joint, and a lot of the time you blamed it on other things.
Yeah.
So I just was debating if maybe it just took that long to establish that that is where the origin of pain was.
Yeah, I think with less than 20% of surgeons doing the SI joint procedure, I think you're onto something that maybe they just didn't realize how important it was, and they were putting it on other parts of the spine.
This is what sacroiliac joint has common with cannabis. Yeah, good one. Because we didn't do research on it for so long, we just neglected it. And because we neglected it, we didn't have a good way of treating it. Because we didn't have a good way of treating it, we neglected it even more. And literally, lots of patients have suffered because of that. But once we figured it out, and our technology was good enough to go through the iliac crest to get to that, it doesn't build a ring, go through a different big bone to get to the joint. Whereas imagine to get to your humerus, instead of going to the humerus or the acetabulum itself, you go through the humerus itself to get to that joint. It sort of requires rethinking of your strategy. But once somebody thought of that, everybody says, duh. Have you guys heard of the phrase Columbus egg? Do you know what that is?
I've never heard of that.
No.
It is a big thing in the history. Columbus, obviously, wasn't a good guy. He was a really nasty person and so on. But when he came back, he was still a celebrity. He literally would be invited to all these courts with kings and philosophers and so on and so forth. And they would literally, he would be a celebrity, a sensation. And Columbus would make fun of these philosophers, mathematicians, and so on. It is attributed to Columbus. Maybe it's not even Columbus, it has existed before. But he would ask these philosophers, these wisest people in the land, to balance an egg on one of the corners. And all of them would do that and fail. But then they would, okay, well, how do you do that? And then he would take an egg, hit it on the table, break it, and then it would stay there. Hence, and then all this philosopher would say, duh, once you know the solution, it's easy. You see this picture here? These philosophers, they're trying to balance it, and they fail, and Columbus just hit it on the corner, and it stays on. Once you know a solution, it's become easy. The problem is only few people have the capacity to think outside of the box and say, you didn't tell me not break the egg, right? So
I can't lie, that was my first thought too. I said, Hamid, he cheated.
Yeah. That's
No,
what I
but-
would call it, a trick question.
Yeah. By the way, lots of intelligent tests actually are measuring that, your capacity to think outside of the box. So once we figured out this is a bad idea, that this caused too much damage, and we have other ways of doing that, then everybody came with the idea, how can we fix it? And then we start doing research about it. Then we start understanding it better, okay? And understanding it, we did. Now, Michael, can you explain this slide to us?
I need to think about the graphs for 1 second.
Yeah, that is what we are good at. I give you a new graph you have never seen before. Just look at the graph and you can make sense of it. Go ahead.
I think I see. Okay, so the SI joint is the main pain generator in 22% of all low back pain. But following a fusion, most likely a lumbar fusion, it's the pain generator in 43%.
Very well said. So meaning that if you are in a community practice and 100 people come to you with back pain, 22 of them don't have spine problem. They have sacroiliac joint problem. If those people, you get 100 people with previous fusion, they come to your office, 43% of them, they don't have spine problem anymore.
Mhm.
They have sacroiliac joint problem. Now, if you are not trained to deal with sacroiliac joint, you're going to tell them nothing wrong with your spine. Everything is okay. You don't have a problem. Maybe you are faking it, and so on and so forth. If you're not trained to do that, you are going to fail to diagnose it. Now it gets even worse. For a long time, we didn't understand why anybody with a sacroiliac joint problem should have leg problem. Why? Why should anybody? This is a pattern of pain in the lower extremity with sacroiliac joint. Do you see what meaning of the chameleon joint is now? It can give you radiculopathy of many, many magnitudes. It can make neuropathy. It can almost fake neuropathy in you. So by why somebody with the sacroiliac joint, almost always, almost 90%, they have as well leg pain. Why?
Why do the patients with SI joint pain have leg pain?
Or radiculopathy, radiculopathic pattern, lower extremity symptoms. Why?
Is it because of you showed us the anatomy
I see,
before.
see.
It was pretty clear that there was a lot of nerves there.
Mhm.
So it looks like a spot where if there's a lot of inflammation in that area, you could get a lot of referred pain.
Mhm.
Yes. An inflamed joint inflames the tissue surrounding it, and guess everything in the pelvis can be inflamed and cause symptom, hence chameleon joint.
Mhm.
Look at that. L4, L5, S1, S2, problem with the bladder function, problem with the cramps, abdominal cramps, and so on. Hence, chameleon joint. Okay. Now, but once we understood, first of all, it is a joint that shouldn't move. It's a joint that can give you various symptoms. We came up to understand as well, what to look for, okay? And then we start doing more research. We understood, what category of people we should look it for. That
Oh.
these are usually younger comparing to spine. This is important in your clinic, you guys. When Alyssa, you and Mike, when you go and see patient in the clinic, this is important for you. These patients are younger, female scoot, meaning more female than male. We talked about that. If you had the delivery within last 2 years, higher rate, and as well, any kind of trauma, preceding trauma is a warning sign. Specifically, often they tell me the pain is worse in the night, because in the night you inadvertently turn from side to side every 20 minutes. Every time they do that, the twisting of the pelvis cause pain and wake them up. So these are, another thing is they put your finger on where the joint is. Like, where's your pain? Now, you would be surprised actually, and that's actually, I think, is disgusting. Most of the time, we spine surgeon, you just, where's your back pain? But how often do you think a spine surgeon asks the patient, show me where the pain is?
Well, you would think
finger.
100% of the time, right?
You would be very, very wrong. And that is actually, it's pointing.
Yeah.
You ask this
I have
patient,
a question, Dr. Bassi, before you switch
Yeah.
that slide. Oh,
okay, go. Which slide do you put on here?
on that slide, I'm looking at what is circled here. Based on BMI, there's not much of a change. Is that
Mhm.
pretty common? Because when I think of how much weight has to be held, you know, especially central obesity, you know, that is held up by the SIJ. I was a little surprised to see that it didn't make a difference based on, you know, a healthy BMI versus an obese BMI.
That's a good point.
Yeah, you know, that's a very good observation, but guess why?
Is it
idea?
maybe because it's held more in the lumbar, or it's in
Well,
other areas?
What do younger people do more? Or what do
Move.
less BMI people do more? If you have a higher BMI,
You're not moving, you're stationary.
and the
Sure.
lower BMI, what do?
They move, they jump, they
Go
run.
jogging, they
twist.
do jump around, they do this and that. They go all night long in dance floor and get arrested by police.
What?
That sounds
What?
like really personal.
Nah. But that does make sense now that you say that. My
Yeah.
initial thought was just, you know, I assume we see if someone came in with an SIJ problem, you know, we always kind of say maybe, you know, lose some weight is always a good.
Well, generally it's a good idea, but it is now usage as well important. And the more you use it, that is why scoot toward younger, active female.
Sure, absolutely.
Yeah, because I see the highest, the 35 BMI at 80 years old
Yeah.
has the smallest likelihood of SI joint pain.
Yeah. So, but let's go back to that it's rare that we spine surgeon, we ask, where's your pain? Put your finger on it. And many times when I do that, they put their hand on it and move it all around wildly and so on. Say, no. Use your thumb and put your thumb where the pain is. Now, and that is sort of when you ask them 3 times, finally, they put their finger right on top of the sacroiliac joint. And we name it, well, it's so important that we gave it a name, 14 test. That if you twice you ask them to do that and they put it within 1 inch of vicinity of the sacroiliac joint or same place, then it's a positive 14 test. Now, so we talked about the pathophysiology, about the history, about the clinical presentation of it. And one of the things is as well important, they have more pain with twisting, we talked about that, but as well, they have more pain going stairs down or down the slope, because then you put more than up. But these are all just a small kind of hints to make you hear more. But then when they're coming to you, you do the 14 test. You ask them to show it to you. You do not think that if they have radiculopathy, it is not sacroiliac joint. It's very comparable. As a matter of fact, this is what most of the time you see. This is the distribution. And do you see a pattern here, Mike? What pattern do you see in this distribution of the pain in the leg?
Looks like L3, L4 area.
L3, L4? Try it again.
Let's say L5.
L5.
L4 is here. L5 is here. S1 is here.
Yeah, it looks like L5S1 pain.
No, heavily L4. Look at that. This is the L4-5 foramen nerve root that comes out is L4. L5-S1 foramen nerve root that comes out is L5. S1 is here. Correct? L3 is here. So heavily L4 and L5. Correct?
Correct.
Okay, yeah. Now
Which
you
makes
can
sense.
disagree with me,
Yes.
and
I think
then you have to just back it up. You don't have to take everything. I can make mistake all the time. You can disagree with me, but then you have to just back it up, okay? So, and here you see as well, you see S1 is very close, but L5, L4, and L5, they literally pass over it. Okay, so, and that is why the distribution is L4 on the side and L5 on the back, less L3, less S1, but yes, it's as well possible. Again, let's go back here. All of them can be involved, okay?
When I hear about SI joints, a lot of the time they refer to the sciatic nerve. So I was hoping just for everyone's viewers, if you want to pull that picture back up, we could show them kind of where that sciatic bundle all goes through and why we have that connection. Because you've heard of the sciatic
Oh
nerve
yeah,
before.
I've had sciatica before.
See, yep, where all of the S1, L5, they come together, which is very close to our SI joints as well, which is why I could see where we would have that confusion or that pain association as well. I just know the sciatic nerve is talked about more often than when we think of L5, L4.
That's true.
So what is the next step? Now, this patient is in your room, Mike. You have the history right. The 14 is positive. What's next?
So I'd do a quick physical exam to see if there's anything else that is suspicious, test sensation, do the distraction tests, and there's some other special tests that you can do. And if all of those make me suspect that it's SI joint pathology, I'd send them for SI joint injections.
But let's start with they're still in your room. First of all, you have an algorithm. You remember we watched this one that says now like some is a side joint, but majority is not. So you have to, first of all, cover that make sure it's not the other things. How do you do that? You examine the spine, you examine the pelvis, you examine for the hip. I have to send them to a specialist if I have to. But then you have to get some CT or MRI from the spine and the pelvis, rule out that is not a pelvic tumor or a spine problem that's causing that. Because even though we said 1/4 of them is sacroiliac joint, 75% of it it's not. So you cannot neglect your homework to get too excited about the sacroiliac joint. So you diagnose the spine, you get the films, you do examine the back and the spine itself, but then you concentrate on the sacroiliac joint. And the next step after that, after 14 tests, is what?
So,
injections. Are we still in physical exam?
Physical exam. There's a mix of
Provocation tests.
Yeah, the provocation tests.
And all of that sacroiliac joint, did you remember all those ligaments there, heavy ligaments? It is extremely hard to provoke the sacroiliac joint because if it was easy, every time you would stand up, your torso would fall in your pelvis if it was easy. So for a true exam, you have to put the patient on the table. You have to get on top of them and use your whole weight for that. And that is another problem with the sacroiliac joint. spine surgeons are way too busy to do all of that. And that is a downfall. That is why lots of people become suicidal with pain, because we spine surgeons are too busy. We don't take our time, or the tests that are out there are so intensive that by the time I'm done with that, I have 5 angry patients. So that is why we are publishing our study, the Sacro Iliac rapid provocation test. So make it easy for the surgeon to do it. So the best way to make somebody sure that they are not going to do something is making it hard for them.
I just spent the last 2 days while I was here, most of Friday and yesterday, getting all that data for that paper.
So you are going to do a service to humanity, Mike.
Thanks, Mike.
So
And a tool-
we got it color coded and everything. The data looks
Good.
really good. So we'll have to
Good.
just run the numbers next.
Well, you see that there. Let me show you the standard tests are. This one, and then distraction test, and then compression test, and then thigh thrust test, and so on, and Genslin test. All of that, what you do, you use your femur and pelvis and torso as a fulcrum to put tremendous amount of pressure on the sacroiliac joint. Like here, patient is laying on a stretcher. You push one leg down, the other one with the knee up to do a counter rotation, axial, sagittal counter rotation in the thing to provoke that joint. It takes a lot of work. This is, the threshold for a surgeon to do that is very, very high, because it is take a lot of time for something that 25% of the cases. And now I'm going to give you a dirty secret of the spine surgeon that I'm not proud of.
Oh.
Another reason that we spine surgeon neglect the sacroiliac joint is it is not paid well. Because it is not paid well, no self-respecting spine surgeon who's busy treating other ailment is going to take half an hour to go through all of that to get paid very, very little from the insurance company to treat and fix this. This is a dirty secret of us spine surgeon, but on the other side, lots of personal tragedies is the consequence of this neglect. Either way, if that is why I think for us reducing the threshold, giving them a better tool, right now, the neurosurgeon, we have like a Canon. We don't want to use that. That is too cumbersome. But I want to give you a small little pistol as a tool with our rapid test. That is more likely that you will use that. So that study, I'm very proud of, that we are creating a better tool for spine surgeon in a busy clinic to do that rapid provocation test. And then if it's positive, they pass it on to physical therapists and other professionals to do the general test and so on. So that, Mike, is a big deal. Good job on that. They take charge on that and make it work. Okay, so, but you do that. If you do 3 provocation tests positive, the sensitivity of that is how much?
3 out of 5, you said?
3 out of 5. Now, let's first of all, Amanda, what do you understand when I say sensitivity of a test?
Sensitivity to the patient, or like?
No, it's a statistical term. In the medicine, everything in medicine is about statistics.
Sensitivity, like being specific versus being sensitive.
I think Alyssa just did a good job explaining it. So it's the difference of being
like specificity versus sensitivity. So specificity is basically how specific it is to that specific situation scenario.
So the sensitivity or the power of a test, there are 4 things. Specificity, go ahead. Specificity.
No, you're okay. I'm more from, sensitivity then is more so how often like it'll be correct, not necessarily under that specific environment situation.
The way I like to think of sensitivity is how often a test picks up what it's supposed to pick up. So,
regardless of.
So for example, how often does our cluster of SI joint tests, if they're positive, pick up that this person actually has an SI joint problem? How frequently are people not flying under the radar with their problems?
So for everybody who want to understand that, this is what you look at. This is a statistical predictive value of a test. Like if something is very sensitive,
PTSD.
it always measure what it's supposed to measure. If specific, it makes sure that if you don't have the disease, it's come back negative. And then there is positive and negative predictive value and so on and so forth. But it's a statistical calculation about how good the test find the disease if it exists. It's if you have 3 positive provocation tests, the sensitivity of test is how much? 77%. Not very high, but it's high enough to start. So what is the next step?
Do you, I don't know if you'll have the answer to this one, but if somebody has even more than 3 out of 5 positive SI joint cluster tests?
Nobody have validated that.
Okay.
That is what's validated. 3 of 5, 77%.
Okay. The next step after that then would be, obviously we need to look at the other pathology, and then we do the SI joint injections.
Well, we did already look at other pathology. It's not the sacro iliac joint injection. Literally, Amanda, have you been with the dentist?
Yeah.
Did they numb up before start drilling?
Yeah.
Did you feel them drilling?
No.
That is the sense, that is the reason for numbing it up. So they numb it up that when they are producing the pain, you don't feel it. The pain is there, you don't feel it. Now, same way, we have lots of diagnostic injection in the spine and in the joint where we just numb it up to see if the pain goes away. Because if the dentist numb up on the left and drills on the right, what is going to be your reaction, Amanda? Not very good. So the spine and the sacroiliac joint are very close, but if you numb up the sacroiliac joint, not the spine, and pain does not go away, the spine is most likely the problem, but vice versa. If you numb up the sacroiliac joint, and you have to do it 3 times, because the first time it can be a coincidence, but you numb it up 3 times, and every time you numb it up, pain or major part of the pain goes away, then you know that part is coming from sacroiliac joint. Now, it's a very important question. Mike, if you go to dentist and he numbs it up today and you go back there tomorrow and he starts drilling tomorrow, how happy would you be?
Not very happy.
Not very happy. Now, the thing with the gum and your mouth is that it's very well perfused. How long does that last when they numb it up? How long does it last?
Usually a couple hours.
Couple of hours, about 4 to 6 hours. Sacroiliac joint is confined, is not well perfused, so it can last up to 3 days. But anything after that is not really effect of the numbing medication. So the protocol for the injection is low volume, so you don't infiltrate everything, about 2, maximum 3 cc, and you put it on the articular part of the joint, on the bottom part of the joint, which is the farthest from the spine, and you confirm it that you are where you need to be. Sacroiliac joint, even it's a low risk injection, is one of the hardest injection to do because it is really not a joint, it's not a space there. You have to just maneuver between 2 pieces of bone, and you hit one bone and then you hit the other bone. You have to maneuver between them and put that material in a sacroiliac joint. But if you do it properly with the CT guidance or with the x-rays, C-arm, with contrast confirmation, low volume, and every time you do that, 75% of the pain goes away. That is the diagnostic criteria for sacroiliac joint. Now, it used to be 3 injections, but the insurance has found out this is such a good procedure. They don't want to waste more money on a 3rd injection. Most of insurances now approve after 2 injections for you to go and fix it. Wow, lots of talk about, I guess you guys have to break this in multiple pieces, this podcast, but we haven't even started to talk about the treatment for sacroiliac joint. Okay, now we diagnosed it. What do we do for it? What can we do for it?
After the injections are done, like once you've exhausted that?
Now, injection can be part of treatment because if I get a needle, so hard work, I got a needle in, there is no reason for me not to put some steroid in. Because steroid don't mask the local anesthetic. Steroid don't work right away. It takes literally a few days, 3 to 5 days for them to start working. But then if it will work, there's 1/3 of my patient after 3 injections, I don't see them for years. So if you work hard, you put a needle in, there is, in my opinion, there's absolutely no reason not to put some steroid in, because then you can give somewhere between 25 to 45% therapeutic effect. After 3 injections, 3 times steroid in the sacroiliac joint, many of these patients, I don't see them for years. So that is already part of the treatment. What else can we do for them besides surgery? Alyssa, what do you think, what can we do for them?
Well, typically, I kind of lean towards more conservative management.
Go ahead, tell me, what can we do?
Physical therapy is always kind of a
What is the
good
physical
option.
therapy for that?
What was that?
What kind of physical therapy can we do for sacroiliac joint?
Like different types of strengthening things like yoga, maybe very light yoga.
Yoga is not part of traditional medicine. You know, in Western medicine, we don't learn or do much of the Eastern medicine. But physical therapy, pelvic floor, gluteal muscle.
Yeah, basically strengthening those muscles to basically eliminate that pain the best you can. But
for most practical purpose, so physical therapy for the lower lumbar spine and the sacroiliac joints are identical. Okay?
Okay.
So what else can we do?
I mean, looking at this list, there's some.
Yeah, look at the list. Read it for me.
Who's gonna do it without the list too?
Hey, what would
Go,
Christopher
go,
say?
go. Read it for me. So
Cheat. So basically, I will kind of go down the list. There's different belts, or they say orthotics here. I know here we fit some different belts as well, but that just kind of gives the patient
Like stability.
yeah, right. That's stability. If it eases the pain, if it works for them, great. That's kind of how my familiarity with.
what do you understand under
binders.
general pain management? What do you understand?
Like
General pain
medicine,
management.
maybe
Huh?
medication.
Like
I think about like
narcotics. So
yeah.
like
Ti-
NSAIDs,
NSAIDs,
ibuprofen.
Tylenol.
Is
Yeah.
general pain management start with medication? Guys, come on.
Conservative treatment.
Ice, heat. Yeah, raise. Well, I
Why
guess
don't you start with easy thing? If you go marathoning and you have pain, you shouldn't be going marathon.
Oh, you want us to say
Behavioral
rest?
modification. What is the pain provocation events that you eliminate? You strengthen the muscle around the brace internally. If that's enough, you build a brace externally. Now, for the sacroiliac joint, braces don't work.
Yeah.
Okay. For other joint, it works. For sacroiliac joint, it doesn't work because that damn thing doesn't move. Common sense. I mean, if the brace reduces the motion, and that reduces the stress to a joint,
Uh-huh.
the ankle brace. But if the joint does move only 2 or 3 degrees, and that's what's causing the pain, there is no way you can create a device that would prevent 2 or 3 degrees of motion.
Dr. Bassi, you know as well as I do that patients love placebo effects, though.
That is part of your general pain management. Yeah.
Yeah.
Okay, good.
So physical therapy, manual manipulation, therapeutic, not diagnostic, SI joint injection, and then this. Do you see that I made it a little less colorful, this one,
Yeah.
this one?
I see it.
So who want to explain to us what neurotomy or RFAs are? And who want to tell us why it doesn't work for sacroiliac joint as well?
So it's destruction of the problematic nerve. And so an RFA stands for radio frequency ablation. So you destroy the problematic nerve. And the problem with doing that in the SI joint is you don't want to destroy a lumbar nerve root and disable the person.
Well, no, the nerves that you want to destroy in any radiofrequency ablation, and we do it all over your body, is destroying the nerves that contribute to the pain and nothing else.
Mhm.
Because obviously, if I put a electrode on your femoral nerve and burn it, you cannot use the leg anymore. Right?
Yeah.
So in many areas, like in facets or the spine, we know where those nerves are. In the lumbar spine, it's much more defined. The facet, the nerve that goes to facet, medial branch blocks. We numb it up 3 times if effect is good. We put a needle in with electricity, we heat it up. We call it radio frequency ablation, but it's actually electricity heats up the tip of your needle and you burn a hole, and that nerve, you kill that nerve. In the sacroiliac joint, those nerves, they don't have a traditional defined path, and there are many of them. So it doesn't really work as well, okay? Just take my word for it. It doesn't work very well. Neither do the belts.
I trust you.
Oh, good. Thank you. So we do all of that, and 1/3 of the patients are getting better. Great. What do we do with the 2/3 of the patient, or half of them?
We discuss further options.
Okay.
Got to do a quick 20-minute procedure.
Didn't used to be.
7 hours. It used to be.
A gallon of blood loss. Devastating. About 20 years ago, this company came up with these plugs that you literally, you nail the sacrum to iliac crest. You go from the outside to inside. You don't go from inside to outside. You don't open up the massive part of the ligament. You just go from outside to inside. You put 3 plugs, 3 nails, and then literally patient get better. There is a massive study. That was a good study, multi-center, randomized. Look at that. When you start treating them, the pain falls off. When you don't treat them, pain does not fall off. Those that are in the control group, once you get to the treatment group, look at them, they fall off.
That is a great study.
Nothing could be more clear about this. This is a good study. By the way, this study was done by University of Minnesota. A major person involved in that is Dr. Pauly, right here in Minneapolis. Now, and this system worked, and I used it 24 of time, but there is something about this, and there's another dirty secret of spine surgeon or spine and musculoskeletal. Now, the study showed if you stabilize the sacroiliac joint, pain goes down. Study shows that if you put those plugs in, the pain falls down. This company who built this went there and said, this is a good look at that. When we put the plugs, the pain falls down, the patient is getting better, but that is only proof that our system works. If you put a screw, there is no evidence of that. It is like if it was something magical, like a Lord of the Ring, some spell or something with that only these plugs would work, whereas these screws would not work. And for last 8 years, 10 years, some insurance companies, based on this wrong, truly devastating abuse of data, they would approve you to do this, but not this. That is the bastardization of the science at its worst. That to take the data that if you do this procedure, it helps people, but is magically linked to this and not this. Whereas it makes sense. It's actually, as a matter of fact, they have done those studies. There are multiple studies there, and insurances are now smarter. But for a long time, they would let us use this, but not this. How much sense does that make?
They got to follow the studies.
Well, the study says if you fuse them, they work. And in the study, they used this. But
right, exactly.
Does that mean if you use this, it doesn't work?
That's not what that means.
That is not the nature of these plugs that makes the surgery successful. It is the fact that you're stabilizing. And guess what? They have done those studies in the engineering. A comparable size plugs versus screws are 4 to 7 times stronger. Meanwhile, they have done those studies as well with the sacroiliac joint because we went mad. I mean, one of the reasons I'm never ever going to use this company for anything at all, because in my opinion, they were very unethical to bastardize the data, pretend that the reason it worked is their device and not the procedure.
Yeah, that's very misguiding.
And as well, lots of insurance company, willingly or unwillingly, lots of people were hurt because, not every surgeon want to use this. As a matter of fact, we know screws are comparable screws to plugs. The screw is 4 times stronger in pull-out. Those studies are out there. We did those studies even internally, but I was a reviewer for one of those studies from China where they compared the plugs versus screws. They've in their study 3.5 times stronger. The screws are 3.5 times stronger. So either way, I started using that, and then I started using the different kind of screws. And this has been just truly a marvel of technology in the last 10 years. Now, 7 hours, 1 hour to 1.5 hours, and some people say, yeah, I can do it in 20 minutes, but when you go and watch them, it's not 20 minutes. It's 20 minutes. When they do that, their assistant is doing it 15, 20 minutes before they start, and they're doing half an hour after they leave the room. Okay, so an hour surgery, good surgery. One of the problems with all of this is you have to poke a hole from all the way from the skin to the sacrum, to the iliac, through the iliac crest to the sacrum. There is a picture of me in one of these surgeries that I sent to Dr. Steiner. I'm doing a podcast on my TikTok, so I cannot show it to you. But in 1 in 7 to 1 of 10 cases, what do? You put a guide wire. First of all, you align it. This is the X-ray of it. This is the sacrum. This is the pelvis. This is the so-called the greater sciatic notch. You align them. This is the ala. You align them. And then I draw the shadow of the sacrum on the skin like this. Then I get the pelvic tilt, literally from promontorium to the middle of the sciatic notch. And middle of the sciatic notch, when you start at the skin, now there are 2 ways of doing this surgery. This is not technical for surgeon. So you can lock your ears, okay, if you don't want to hear that. You can say la, 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 la. So there is a so-called true lateral to medial approaches, and there is so-called perpendicular to sacroiliac joint approaches. I use perpendicular to the sacroiliac joint approaches, and I'm going to tell you why. First, in the true lateral view, when the sciatic notch is aligned and the ala is aligned, I draw the shadow of the sacrum on the skin. I get from promontorium to the middle of the sciatic notch. If I enter the skin here, the angle allows me that rest my tip of my guide wire anterior to the sacral shadow on the iliac crest. But I'm not on the sacrum, I'm on the iliac crest. By the time I pass the iliac crest, I'm truly centered on the sacrum. This angle allows me to do that by choosing the entry point of the skin at the middle of the sciatic notch, entry to the iliac crest, anterior to the shadow of the sacrum. And then obviously the level, depending on where you want to put that, you pay attention to S1, S2, S3, because sacrum is made of 5 bones. S4 and S5 usually are rudimentary. There's lots of variation, and they can bend. They almost like a curve. But if you pay attention to S1, S2, S3, you're good. And you choose the center of gravity of the S1, S2, S3, which is obviously closer to almost the disc of the S1, S2. So once we choose the entry point, we go to so-called inlet view. the inlet view is practically the true axial view of the sacrum. That's the only spine segment that you can get the axial view because it bends and goes back. So this is the inlet view where you see sacroiliac joint, the pelvic floor, and you have to go back and forth until those three, S1, S2, S3, the three shadow become one. This is almost like a religious thing. The three become one, right? So here there are three shadows, they come together, become one. This is that you make sure that your trajectory doesn't take you to the pelvis floor. Mike, what are the structure here?
Is that the coccyx?
Looks like
No,
the
it's not
bladder.
coccyx. Coccyx is the continuation of the, you're looking at you directly at the sacrum and the coccyx. No, this is not coccyx. Okay, let me make it easy for you. These are structures that you never ever want to mess with. Iliac artery, iliac vein, femoral nerve, bladder, pelvic floor, rectum, and so on and so forth. So your trajectory has to avoid anything here. That is what the inlet view is for. And then you go to outlet view. Outlet view is a true AP view of the sacrum because sacrum comes at an angle. A true outlet view, and here you see the L5S1 disc, you see the foramen, you see the sacroiliac joint and ilium, and so on. So in these two windows, you align your wire to go inside of the sacroiliac joint. And now, actually, the hard part start. In a regular system, to put like these screws in, you put a small drill in, then you put a big drill in, then you put a tap in, and then you take everything out while the gag wire is in place, and you put a screw in, and then you repeat that 3 times. Or at least 2 times, because if you do it only one screw, it still can rotate around the first screw. At least you have to add the second screw so it doesn't counter-rotate. So, what do you think sometimes what happened when I put a 1 centimeter drill in and I take the drill out? Then I have a 1 centimeter hole from the sacrum and the iliac crest from the spongiosa outside. It bleeds like you have never seen before. I have lost, worst case, 700 cc in 4 minutes. It pours blood out. It can be very scary if you are not a surgeon. If you're a surgeon, you say, another day in paradise. You just keep going, you plug it with the screw and then pack it and so on. You have to be very efficient, very, very fast. And that is the reason why I'm really proud of Trident. In Trident, this is all you need. You don't put a drill and take it out. You'd never come to the opportunity to bleed out because the screw that you put in is its own drill, and you don't put the screw in and take it out like you would do with the drill, put it in and take it out. And as well, you see the holes in the Trident? It compacts the material in it. It plugs its own hole as it goes in. So 0 time it has happened with Trident that it starts bleeding like it would with any other system when you put the drill in and take it out. Additionally, remember we said you have to put more than 1 screw in? Trident, with a regular system, you have to go all the way back to lateral, start a new entry point, and repeat all of that again. In Trident, once you put the first screw in, the second and the third screw go through the sleeve of the first screw. Literally, you're done. Once you have the first screw in, you're done. So you don't go to lateral and come back. We have done on a patient this Trident in skin to skin in 12 minutes, and the average take us 15 to 20 minutes. And you don't have to go back and forth. And so it made really this truly a marvel of technology to fix the sacroiliac joint. Now, additionally, there's this system that has all used screws and so on. Like have some picture I want to show you. Trident, it has holes in different places that makes bone grow into that. This become part of the fusion. There's some consideration, do we really need to have fusion or not? In my opinion, absolutely. Fusion, not instrumentation, just putting the screws in, but the bone growing gives you the final stability. And by having all these holes here, bone grows into that. By the way, this is titanium. Bone grows into the titanium. This becomes part of the fusion, not only instrumentation. But
Do
what's
you
important, go ahead.
do you pack that with, because I know during your OLIF surgeries you use tricalcium phosphate and mix it with bone marrow. I
Yes.
wasn't sure if you pack the Trident screw with any sort
Yes, we
of.
do. Yes, we
Yeah.
do. There is a one step here that after the screw is in, before you take the sleeve out, you put the tube in and just pack it with a biologic. And you do all of that, including closing the skin, in 15 minutes. So
How big are the incisions for this procedure?
1 inch, that's all it takes to do this surgery, 1 inch. And then for the first few weeks, we ask the patient not to step on that side because you just got a surgery, it's painful. But vast majority of my patients tell me after 2 weeks or maximum 3 weeks, they could put weight on it, no problem. And that is where the miracle joint part comes in. I noticed when I see this patient after the surgery, they stand up, they hug me, they want to hug me. I'm not a big hugger, but they want to hug me because they have been told for 7 years, nothing wrong with you. It's all in your head. I do a 20-minute procedure. Their life changes. They are the most thankful. They are the huggers. Okay? So we went way too long for this, but I think it's also important information.
I have one more question for you.
Please.
What are the anesthesia implications since it's now such a shorter surgery? Are there any implications for anesthesia that makes it a safer procedure?
Yeah, well, shorter procedures are always safer. And we have this graph that we show regarding OLIF. Every additional half an hour on the anesthesia at 17% of the combined risk of the surgery. But I think it has, beyond that, it has the implication here. The anesthesiologists need to know this is not a 2-hour surgery. Because now when we started this, I was done with the surgery. It took them longer to wake up the patient after the surgery than it took me to do the surgery. But an anecdote as well.
I was curious about if they were able to use like less deep sedation for it so that it would be less risky. I'm not sure.
Science for itself. That is something they just need to know. The input I can give them is that how long it's going to take. And that input need to be accurate because, you ask the surgeon, how long going to need for that surgery? They say 2 hours. It's going to take them 6.5 hours. They say, how much blood did you lose? Oh, 300 cc. Or they lost 2,300 cc of blood. We surgeons are really bad at those estimations. But that is what we do different. We are very accurate. We gather our data. It's everything collected firsthand, not by surgeon. We know what it takes and so on. And you communicate reliably to the anesthesiologist. This is a half an hour surgery. That's what I tell them, even though it takes less than that. And then they can adjust it's a science for itself. They adjust their gases and the medication to that thing because they can do that. They can play around and really give us but if they think it's a 3-hour surgery and I'm done in half an hour, they're not ready for it. This is an anecdote really happened. In the university, they need 5 to 7 hours for a 1-level OLIF. I was doing a 2-level fusion. After 45 minutes, I told them I'm closing. All of a sudden, the head of the anesthesiologist came from up. So first the question is, are you interrupting or are you abandoning the surgery? I said, no, we are done. We are closing. He said, you're joking me because they're not used to, she wasn't prepared that a 2-level fusion will be done in 50 minutes or so. And so, yes, back to answer, huge implication. Ask any anesthesiologist or anesthetist about longer surgery, shorter surgery, which is safer and so on. They can tell you all the stories. There's a good description from Beverly Trujillo, when we went to El Paso, did this surgery. In the dinner, she explained that, how easily that patient, they cruised and woke up and so on. She explained that very well. Maybe we should attach that to the comment for this podcast, because there's not a question even. And guess what? In the places that they are used to do open old-fashioned surgery, they notice, for them is like a miracle how fast this patient recover, how fast they go home. By the way, when I was in the Detroit helping another surgeon, they were asking me if the patient needs to go to ICU, because for them, for the way they do the surgery, 1/4 of the patient go to ICU after a spinal fusion. 8-hour surgery, half a gallon of blood loss, it's unstable. How many times do you think, Mike, I have sent my patient after my surgery to ICU? 1,500 cases. How many times have I sent a patient to ICU?
I'm going to guess 3.
Actually, exactly, it's 3. The first one was a patient with a BMI of 62, and even with the 2-hour surgery, they couldn't take the tube out. Patient was fine. Patient went one night there with the tube. The 2 others, they were patient for Olive. They had liver transplant. We did a T10 or L1 to S1, so 2 different procedures, liver transplant, coagulopathic, and so on and so forth. And that every single of them after one night was removed from the ICU. Whereas for open old-fashioned surgery, they stay weeks sometimes. Yeah. Okay. I have nothing else to add to the sacroiliac joint. Now,
I do not believe you.
Me neither. I don't believe that. I have a question.
yes.
How many non-trident SI joint procedures did you do before you decided that you wanted to fix it, and then you came up with the trident procedure?
Well, about 150.
150. That didn't take very long.
No, well, 150 is a lot for a surgeon. Most of us surgeons become proficient in a procedure 5 to 10. We are a smart group of people. We don't need 150 to become good at some procedures.
We didn't doubt that at all. I did have a question though. Because you had said that 20% of spine surgeons are taught or less than 20%. So who do they expect to do the surgery, or who do they teach? Because in my head, the SI joint is, partially spine, partially pelvis. But to me, I would almost still associate that with, spine.
Yeah.
Mm-hmm.
So I was just curious. I was curious as to who they actually train or who they expect to do that surgery if they don't expect spines.
Nobody, trauma surgeon who know nothing about spine. And
interesting.
That's why it was a discrepancy. By the way, this is the study that they compare those plugs to the screws. They are 4 times stronger. Look at that here. Okay, the pull-out value 4 times more. Okay, wow. And this is the study that I reviewed. But as well, that my beef with these companies, that why I will never use them again, is because, they say this is the best steakhouse. Go there. The study said the procedure works. It's a good procedure. It helps people. They said this is the best steakhouse. But the only way to get to the steakhouse, you only have to take this map with this car. Otherwise, you won't get to that steakhouse. Does that make sense what I'm trying to tell here?
Yeah.
You can use the information about this is a good steak in that place, and you bastardize the data that is contrary to every point, every millimeter of science and being an academic, to say the only way you can get there through to using this route with this car. If you use your Bugatti and take a different path, you cannot have that good steak. And they
know we'll have to leave our Bugattis at home.
Yeah, Mike's is in the garage.
Yeah, well, they convinced lots of intelligent people in the insurance companies of that. And that is just evil. That is just evil.
It is.
Yeah. And in medicine, we cannot be evil. That is the core of it.
Cannot be greedy either. That's where a lot of the evil comes from, is greed.
Well, and that's why Inspired Spine focuses so much on research. Every patient's information goes towards research.
Yeah, and I'm just flashing through all the studies that they show you where do we come from. We do truly evidence-based medicine to its core. So I'm going to unshare my screen. This was long. You probably do need to break it in few pieces, and I leave it up to you. Put one piece that is all of it, but few pieces that are separate. I hope all of you are smarter now than 2 hours ago.
I can say I am.
Yeah, I'm actually thinking, do I need to get my SI joint looked at?
Well, if you walk and run and you have pain in that location, not every of them need surgical treatment. But this is one of those things that is so common, we cannot neglect it, and people are neglected. So every time you see a patient, always think about it. Have you guys, you're too young to have seen that movie with Kevin Costner called Field of Dream. Have you seen that? It is a very soulful story about this guy. He built a field of dream for baseball, and then when he builds it, the whole community gather around it. And there's a saying, it's a field of dream. You build it, they will come. You make yourself knowledgeable. When I didn't know anything about that, I was saying, I don't see this patient with sacro iliac joint. They say they are everywhere, but they're nowhere. I don't see them because I wasn't looking, because I didn't have the tools to see them. I didn't have the diagnostic tools to see them. Once you hone on your diagnostic tool, these patients are everywhere.
Dang chameleons.
Yeah. Okay. Any other question?
I don't think so.
I'm Dr. Abbasi for Essence. Welcome to our podcast. This was extraordinarily long, but was necessary.
I'm Melissa Haber.
I'm Amanda Armagast.
I'm Mike Yeager.
Okay. Thank you for your attention and being with us in this podcast.